Welcome back, everyone. First of all, I would like to invite our chair, Dr. Abbas Khoker, who is head of department at New Hospital. Sir, if you could just come on the stage, please. Thank you. So our afternoon session is mainly on advanced breast cancer, and I would like to invite our first speaker, Dr. Fahad bin Asad. He's a consultant medical oncologist at Illinois Cancer Center, United States. He's won an award by ASH IPIG award for his work in paroxysmal nocturnal hemoglobinuria. I'll hand over to Dr. Asad, please. Sure.
Good afternoon, everyone. I know this was a lunch session, so maybe the people are coming in, but we'll start the session because the time is limited. So going on the same theme that I was discussing previously about the HER2 low group, now I'll take you to the metastatic HER2 setting, metastatic breast cancer. And, in this, I think there's slides that, yes, okay, so we're back. So in the metastatic, in any cancer, actually, if you look at the survival is improving. So what it means is that metastatic still continues to be an incurable disease, as we know about, but there are different multiple efficacious agents almost in the metastatic breast cancer will develop progressive disease. And it remains uncertain what's the best treatment choice for individual patients, especially when we have so many of these things in our armamentarium now. The goals of therapy as for any metastatic disease is prolonging the survival, controlling the symptoms, maximizing toxicity, or minimizing as much as possible the toxicity associated with chemotherapy and looking at the quality of life of the patient. This is our theme for all breast cancer patients, metastatic, and in general in all malignancies that we treat in our practices. Now, with the survival, I wanted to share this data. This is the 5-year breast cancer specific survival, and this is according to the subtype. And if you look at the hormone positive, the HER2 negative group, that's in the stage 4 setting, the biggest survival of 47% in 5 years, compared to the triple negative, which is the highly aggressive group, 17%. These are the survival curves. But look at the triple positive, 39% survival, and compared to the hormone receptor negative HER2 positive 24%. This used to be low, but now with these HER2 directed therapies, we have come to the second number in the breast cancer specific survival. HER2 amplified breast cancers, this account for roughly 20% of the invasive breast cancers, poor prognosis. Tumors are likely to be high grade, lymph node positivity, and high risk features will be present because of the biology of this HER2 status of the patients. Wanted to share with you the targeted therapy right now that we have. These are the targeted monoclonal antibodies, which are the trastuzumab, pertuzumab, Perjeta. The new one on the block, margetuximab, is there as well. These are the monoclonal antibodies. I'll take you to the TKIs. So tucatinib is the selective HER2 receptor antagonist that has just recently come into the foray, and we have got a new HER2 climb study for this. Neratinib and lapatinib are also TKIs. Neratinib is the pan HER2 receptor antagonist. It's irreversible. Lapatinib is the reversible agent in the TKI setting. Going to this HER2 ADCs, which is the antibody drug conjugates, we have got TDM1, we have got TDXD, and we went over this a little bit. I will go over this a little bit more in detail, how these things work in our metastatic HER2 positive breast cancer. Cleopatra, this was the first trial which has in the phase 3 setting really showed phenomenal results. Nothing has been able to beat this study till to date. We are making some headway in treatment paradigm change, but this still remains our first go-to therapy for the metastatic HER2 positive breast cancers. This was a placebo plus trastuzumab plus docetaxel, which is the chemotherapy, compared to Perjeta and Herceptin plus docetaxel. Greater than 6 cycles, maybe 6 to 8 cycles of chemotherapy is given. The dosing is right over here. You give a loading dose and then you give a maintenance dose. What it showed was the primary endpoint, progression-free survival was approximately 18.5 months with a combination arm of Perjeta, Herceptin, and docetaxel, 18.5 months compared to 12.4 months. Hazard ratio 0.62, so roughly 38% lower the risk of progression or death. You can see the curves actually separating nicely from the get-go. Overall survival benefit, as you saw, that the progression-free survival was quite phenomenal. So translated into the same overall survival benefit of this study. And if you see over here, roughly a difference of 15.7 months in the combination arm, we could see like 58.5 months over here compared to 40.8 months. So this was quite a substantial overall survival benefit that you usually don't see in the metastatic setting. So first line, I would say THP is our go-to. Remember, it's okay to stop therapy after 6 to 8 cycles of chemotherapy because you would have obtained maximal benefit that you wanted to achieve, or there will be toxicity associated with docetaxel. It's not a very easy drug to take. Similar cardiotoxicity profile of Perjeta addition to the trastuzumab, we did not find any great toxicity cardiac standpoint-wise when we combined it. Diarrhea was present, but tolerable. You could give supportive medications to control it. Now coming to the TDM1, we really were looking to TDM1 after THP therapy in the Catherine trial. TDM1 came out in the patients who had did not have pathological complete response. TDM1 went into the standard of care. So this is an antibody, monoclonal antibody conjugate, and it has got ADCC as well, which is the cellular cytotoxicity. It inhibits the HER2 signaling, and it also inhibits the HER2 shedding. So this is internalized as you have a TDXD. M-tansine is released. This is a microtubule polymerization inhibitor, and that's how it functions. Emilia study was the next one, which was in the prior taxane and trastuzumab. We are looking at second-line therapy right now. Progression on metastatic treatment or within 6 months of adjuvant treatment were enrolled in this trial. TDM1 was given at 3.6 milligrams per kg every 3 weeks compared to capecitabine and lapatinib. Primary endpoints were progression-free survival by independent review. Overall survival and safety were also the primary endpoints in this study. And you see, like, it did show a benefit at 9.6 months median PFS compared to 6.4 months in the capecitabine lapatinib arm. Hazard ratio 0.65. So again, the curves are separating apart from the early decline in the curve, which is the patients who were high risk probably fell down over here. But then it showed a separation, which was nice. And overall survival benefit did translate, although not as much as the initial THP therapy, but it did show overall survival benefit of 30.9 months compared to 25.1 months, hazard ratio of 0.682, again, statistically significant. So then we come to the kind of new kid on the block. As we said, in the HER2 low setting, it took by storm. But this is a humanized anti-HER2 immunoglobulin monoclonal antibody with the same amino acid sequence as trastuzumab. This has got a payload of topoisomerase 1 inhibitor, and it has got a tetrapeptide cleavable linker with it, which is right over here. And deruxtecan is the chemotherapy payload. So in essence, when I think about this, it's kind of a chemotherapy. It's a smart bomb to call it, like it really acts on the receptor end. So high potency of the payload is there. It's a high drug to antibody ratio 8 compared to 3.5 in the TDM. Payload has got a short systemic half-life. It's a stable linker that it has, and tumor selective cleavable linker. So anytime you've got tumor, you don't have an off target too much of an effect because of this property. And it has got a good bystander effect as well. So Destiny Breast 03, this was in the metastatic breast cancer as well. In this space, you have got unresectable or metastatic HER2 positive breast cancer previously treated with trastuzumab and taxane, as we have done in the previous trials. We have used TDXD, which was from the initial phase 2 trials, 5.4 milligrams per kg dosing, compared to TDM1, which was kind of like, this was an important comparison because TDM1 was in that second line before this. We have got this progression-free survival by an independent review committee as a primary endpoint, key secondary endpoints of overall survival. Again, you see a very nice separation of curves. So TDXD again took a notch further, and we have got this. This was not statistically, this was presented at ESMO in 2021, but at that time, median progression-free survival was not reached. TDM1 was 6.8 months. Again, the hazard ratio, this hazard ratio 0.28 is being quoted everywhere. And if you see the p-value, it shows like 10 to raise minus 22, which is kind of unheard of in this setting. So this is kind of very exciting. DB03 and you see like if there was such a significant progression-free survival benefit translated into overall survival benefit as well. And we have got a 12-month overall survival rate of 94 months compared to 86.9% of the overall survival. So this is quite phenomenal because TDM1 was doing very well in this space. Now TDXT is beating it to that as well. Adverse effects actually compared to TDXT and TDM1, we have got this ILD, which we always get concerned about. Grade 2, I think in all the studies we held TDXT because it's kind of catastrophic for the patient, and we did have deaths in the earlier trials from the ILD setting. So grade 2, 7% in TDXT compared to 0.4%. So ILD, interstitial lung disease, is always a concern. You want to start steroids early, especially grade 1, even if you have got a asymptomatic patient with just CAT scan findings of interstitial lung disease, you want to start them on steroid before they head up to grade 2. People actually stop TDXT on grade 2. And just going by the point, the ejection fraction decreased 2.3% compared to 0.4% in TDM1. But if you see grade 3 and grade 4, like it's always a concern, but really nothing showing up over here. And I think this is because of the payload, because this is a chemotherapy agent. You're just using a HER2 receptor for kind of targeting that agent. So first line PHP remains the standard of care. Second line TDXT kind of going into the bigger chunk of the portion in the second line setting compared to a TDM1. Remember about the lung toxicity, as I mentioned. TDM1 thrombocytopenias is a big one. LFT derangement is another one. So you want to keep an eye on these things and change the dosing accordingly. This is the NCCN latest version in the guidelines. You can see adotrastuzumab, which is TDM1, second line, along with the Reduxtic and TDXT coming into the NCCN guidelines as well. So then we come to the tucatinib, which is kind of in the fourth line right now, but we'll see that it's you can start it upfront as well in certain conditions. So this has got activity in refractory HER2 metastatic breast cancer and brain metastasis, very favorable PK properties. Overall response rate in heavily pre-treated population was 14%, and clinical benefit rate was 27%. This is an oral drug, much less EGFR toxicity of skin rash and diarrhea. And you can see over here, these green is with brain metastasis and blue ones are without brain metastasis. So you can see the plot out here. It shows significant benefit. Overall response rate of roughly 21, it's roughly 61% in there. HER2 CLIMB study is the one that we have got this metastatic HER2 positive breast cancer, prior treatment with trastuzumab, TDM1, pertuzumab. So you can see, but these patients did have brain metastasis. So HER2 has got a significant property that it does predispose you to brain metastasis. And I think this is the target population for the HER2 CLIMB. We've got tucatinib, trastuzumab, capecitabine, and then these are the dosing compared to placebo, trastuzumab, and capecitabine. This was the study design. And you can see that there was a hazard ratio of 0.54 for the progression-free survival. So 46% decrease in the risk of progression or death. And you can see how the plot comes around and it shows significant benefit over here. With brain mets, it holds true as well. You've got a hazard ratio of 0.48, very significant. So overall survival benefit is showing a hazard ratio of 0.66. And you can see 21.9 months compared to 17.4 months in the placebo arm. NALA study is the other one which I wanted to mention, neratinib, capecitabine, compared to lapatinib and capecitabine. The primary endpoint was progression-free survival. Again, these patients have been pre-treated for HER2 positive breast cancer in metastatic setting. Neratinib was the winner in this trial, neratinib plus capecitabine. So this did show one-year progression-free survival of 29% versus 15%. This is another one, the margetuximab SOPHIA trial is again comparing in this heavily pre-treated metastatic breast cancer. Margetuximab is a FC engineered HER2 HER2 antibody targeting agent. So it has got a role in which it's activating immune cells and inhibiting the inhibitory immune system out there. So margetuximab will come into the foray as well. And this was the primary endpoint was overall survival, secondary endpoint of progression-free survival. This did show a benefit, median progression-free survival of 5.8 months compared to 4.9 months. Not all that much compared to trastuzumab, but it did show positivity, and we are still following up on these trials as well. So in summary, I would say first line THP, second line, I would use TDXD. TDM1 can also be considered. Fourth line, tucatinib, capecitabine, trastuzumab. Upfront brain metastasis, I would say I would want to use this therapy upfront. Depends on the clinical picture, and we can discuss about it later. All the other agents can also be used once you are off of the standard of care, and I think all of these have shown activity in these heavily pretreated population. Again, going by the algorithm, I think this would be my algorithm that I would want to use, first line and second line and the third line. Conclusions. So if you want to say a HER2 positive, hormone receptor positive, it's okay to use endocrine therapy with HER2 directed therapy. I would use a combination in this setting. I think it will benefit the patients more. Never use a CDK4/6 inhibitor or CDK inhibitor outside of a clinical trial. We don't have good data if you want to combine this in the setting of HER2 positive, hormone receptor positive. And even PARP inhibitor, even if there are germline BRCA positive, we don't have trials or data about PARP inhibitions, which can be put in outside of a clinical trial. These data will come in a little bit, but not right now. I think this is your focus point out here. And I think you can go easily to fourth line or fifth line of therapy right now with these agents. So thank you very much for listening. And
thanks a lot, Dr. Asad. Our next speaker is Dr. Haider Abbas. He's a consultant medical oncologist at Queen Elizabeth Hospital, Birmingham, UK. He has done PhD in receptor pharmacology and sits in various national and international advisory boards. Dr. Abbas, please. Sorry for that. We just need to sort out a presentation of Dr. Abbas. Meanwhile, can we move on with the next presentation of Dr. Ahmad Hanif, who is an assistant professor of medicine at Geisinger Commonwealth School of Medicine, USA. Thank you.
Okay, I want to start from here. Thank you. Okay, so this is now no, this is not where I wanted to be. Okay, so again, back with hormone receptor positive, HER2 negative breast cancer, but this time metastatic. Again, no disclosures. So for metastatic disease, which is hormone receptor positive and HER2 negative, we have a lot of things to consider before making treatment decisions. The location of the metastasis, the number of sites involved, the need for rapid response versus can we go slow, what are the prior therapies that have been received. Generally speaking, hormonal treatment is the way to go. And chemotherapy comes after you've run out of all the hormonal treatments. And generally, there's also a correlation between the degree of response and the strength of the ER and PR expression, but that's not always the case. The goals of treatment obviously is improvement of quality of life, slow the disease progression, and prolong survival while minimizing treatment-related toxicity. The images that you can use to detect metastatic disease would be a CAT scan and bone scan. Now, most common initial site of metastasis would be bones, liver, and lung. And sometimes, because these can be sclerotic as well as lytic lesions, the lytic lesions can be missed on bone scan. So the PET scan can be quite useful if otherwise there's no other signs of metastatic disease. MRI brain, we can defer until any symptoms arise, because this is not the kind of breast cancer which goes to the brain frequently. Talking about which cancers go to the brain frequently, HER2 positive and triple negative breast cancer have a much higher frequency of brain metastasis. About a quarter to a third of the patients with metastatic HER2 positive and triple negative cancer would have brain metastasis. Hormone receptor positive breast cancer likes to go to the bones. 68% of the time, that's the initial site of metastasis. Triple negative cancer likes to go to the lungs. And we can consider biopsy of the metastatic site in selected cases to confirm the diagnosis and to determine receptor status. One thing that we always want to do is make sure that we are checking for HER2 each time we biopsy, because there could be HER2 positive and negative clone. It's not a founder mutation. So you can just biopsy the HER2 negative clone and think that it's a HER2 negative disease. Tumor markers can be used, but they have to be used very carefully. Just based on the level of tumor markers, we cannot change the treatment. So CA2729, CA15.3, and CEA, they can be used, but they have to be used in conjunction with the imaging. And they basically are to guide how frequently you have to perform the imaging. Circulating tumor cells, the preliminary data looks very promising, but it's still strictly investigational at this time. Now, if we start with postmenopausal hormone receptor positive metastatic breast cancer, the treatment of choice usually starts with some form of aromatase inhibition. And aromatase inhibitors, all of them have been tested, have been looked at in randomized clinical trials compared to tamoxifen, and all of them did much better. So tamoxifen by itself has a progression-free time to progression almost like around 6 months in all trials, and the aromatase inhibitor significantly increased that. We cannot compare the data across the trials, so they overall look the same. So until proven otherwise, anastrozole, letrozole, exemestane, they can be treated interchangeably. This was the Atlas trial, which established the superiority of anastrozole to tamoxifen. It was done in the early 2000s, and it was done in postmenopausal women. And this trial established that in postmenopausal women, and aromatase inhibitors like anastrozole are definitely superior to tamoxifen in terms of progression-free survival, and eventually overall survival was also proven. So postmenopausal hormone receptive metastatic breast cancer, if the disease progressed on aromatase inhibitor, we call it the endocrine hormone resistant disease. So if it progresses on an aromatase inhibitor or less than 12 months after completion of adjuvant therapy with an aromatase inhibitor, the next step can be tamoxifen or fulvestrant. Now, this is old stuff, so I'm just going through that, but the treatment landscape has remarkably changed since then. Also, we can do is we can switch from a non-steroidal aromatase inhibitor like letrozole or anastrozole to a steroidal one. Again, this is rarely done these days. Usually we combine it with something else like everolimus, or we can add fulvestrant to aromatase inhibitor. So this is still in the guidelines, but rarely practiced. So about 5 years ago, CDK4/6 inhibitors came on the scene and really really changed the landscape of hormonal treatment for this kind of cancer. They were initially developed by scientists who were working to establish a new line of treatment in mantle cell lymphoma, because as you know, cyclin D1 is always amplified in mantle cell. But this is the same pathway which inhibits the CDK4/6 as well. And CDK4/6 overexpression along with cyclin D1 amplification is a pathway through which these cancers, they acquire hormone resistance. So, so inhibition of this pathway, inhibition of cyclin D1, CDK4/6, and RB protein is an effective therapeutic strategy for hormone receptor positive breast cancer. Now, talking about the approval, so the first drug to be approved in this setting was palbociclib, and the data regarding palbociclib and the ribociclib literally came with a difference of a few weeks. I think the palbociclib came first, and their trials are always named Paloma. So this was the Paloma 2 trial, which was a randomized controlled trial. And it improved the progression-free survival from 14.5 months to 24.8 months. Now, obviously, there were side effects. There were 80% of the patients experienced some kind of neutropenia, and about 2% febrile neutropenia. Other cytopenias were also seen. But you can see that the curves nicely separated, both on investigator assessment and on central assessment. And later, we're going to see why it's important to maintain adequate follow-up for a disease like breast cancer, which is a slowly progressive disease, because eventually it turned out that this drug does not prolong the overall survival for some reason. But so within this trial, the Paloma trial, if you look at the subgroup analysis, almost all the subgroups, they benefited from palbociclib. Everything was better. So the combination of palbociclib and letrozole was approved as a first-line treatment for hormone receptor-positive breast cancer after this trial. And then the Paloma 3 trial, the results came on, I think, about a year and a half afterwards, and that was in the second-line setting. And they combined fulvestrant with palbociclib, and they proved that it again improves the progression-free survival. Now, when you look at the overall survival, actually the hazard ratio is touching 1. The confidence interval for the hazard ratio is touching 1. So that means it's not statistically significant, which was a surprise. When they did the subgroup analysis, they found out, because this is second line, so patients have already received 1 line of endocrine therapy, that the benefit, the overall survival benefit was improved only in the endocrine sensitive group. So in the endocrine resistant group, those patients that progressed on or soon after the endocrine therapy, or I think they define it as any response lasting less than 6 months on endocrine therapy, they basically did not have any benefit with palbociclib. And a few years later, actually, just this year, the Paloma 2 trial, the trial we just discussed in first line, that also reported that there's no overall survival benefit. So both the trials for palbociclib actually turned out to be negative. And that was a bummer for many patients who were on it after FDA approval. Again, this is the Paloma 3 trial with palbociclib and fulvestrant. As you can see that these are the patients who are sensitive to endocrine therapy. There's a nice separation of the curve here, but the patients who did not have this sensitivity, the curves were overlapping. There was no statistically significant survival. Looking at these trials, various subgroup analysis was done, trying to find out if there are any predictors of response to CDK4/6 inhibitors. We looked at the hormone receptor expression level, the strength of the ER or PR positivity, the PIK3 mutation, ESR1 mutation, and basically nothing. But none of them were predictive of response. Then the trials for ribociclib came on, and they are named after Mona Lisa. So ribociclib in the first line was also combined with letrozole, and that was in postmenopausal HR positive advanced breast cancer. and significantly prolonged the progression-free survival. The overall response rate was 52%, which is pretty impressive. But just very recently, we have also confirmed now that ribociclib also confers an overall survival benefit. So about 63.9 months compared with 51.4 months. So ribociclib and letrozole is now the preferred CDK4/6 inhibitor use, and palbociclib is kind of falling out of favor. Actually, should not be prescribed after we know that it does not prolong overall survival. Now, Monarch 1 trial, this is another CDK4/6 inhibitor. It's called abemaciclib. Now, this is very encouraging data and very hopeful data as well, because this drug technically is, I'm strictly talking about the lab. In the lab, it looks much better than the other CDK4/6 inhibitors because it binds to the CDK4/6 much more potently, and it carries less incidence of cytopenias. So we know that with ribociclib and palbociclib, the cytopenias, they prevent a continuous dosage. So you have to give it for 21 days and then 7 days off, or sometimes 14 days and 7 days off. But in abemaciclib, it could be a continuous administration of the drug, which is really helpful for patients to remember to take the drug. So this was a phase, so this was not a randomized control trial. This was just a single arm study. And the overall response rate was 19.7%, which is not that impressive, but these were heavily pretreated patients. Most of them were third line and fourth line. So this is kind of comparable to the response that we observe with cytotoxic chemotherapy after patients have progressed on taxane. So, and obviously much less toxic than cytotoxic chemotherapy. So this trial was very encouraging. And then the Monarch 3 trial also looked at the combination of abemaciclib, the use of abemaciclib, but this time in combination with letrozole, not a single agent. And this did prolong the treatment-free survival. But if you look at some subgroup analysis, the bone-only disease did not benefit from the addition of abemaciclib. The response was not significant. The improvement in response was not significant. So probably if you don't have visceral metastasis or just bone-only disease, then the addition of abemaciclib is not really conferring any response. And so now just moving on, and we're going to talk the overlook of CDK4/6 inhibitors in a minute, but just a quick word about premenopausal HR-positive breast cancer, because all of this was either like the ribociclib trials were strictly postmenopausal, and the other trials did not differentiate. So in the premenopausal, we always go with some form of ovarian function suppression. In this day and age, we rarely use surgical ovarian resection, probably for a non-affording patient once in a while. But otherwise, GnRH agonist is as good as a surgical ovarian ablation, and the two most common ones are gusarelin and Dupron. And if the patient has ovarian function suppression and they're on tamoxifen, they are treated very similarly to postmenopausal women. So you can go with all these treatments that are approved for postmenopausal women regarding the CDK4/6 inhibitors. And then the only trial that was specifically done for premenopausal women for the use of CDK4/6 inhibitors was the MONALEESA 7. And this was first-line ribociclib plus some form of endocrine therapy. And the endocrine therapy involved either gusarelin with an aromatase inhibitor or tamoxifen. And it did show that there is a significant benefit in overall survival and progression-free survival. So ribociclib had overall survival benefit confirmed both in the postmenopausal and in the premenopausal setting, but in combination with endocrine therapy. So this is an overview. Paloma 2, this needs to be updated because it should not be up on top. The overall survival benefit has been there's actually no overall survival benefit. And the ribociclib, it significantly prolonged PFS and OS. Abemaciclib, we don't know about the OS yet, but the PFS benefit looks promising. And first-line premenopausal ribociclib does confer a significant benefit in PFS and OS. So this is first line. Most of these were done with aromatase inhibitors, but you can combine them with fulvestrant as well. When we talk about second line, most of them were combined with fulvestrant in the second line. And again, all three had good PFS. Palbociclib, no overall survival benefit. Abema, we are still waiting for the overall survival. Ribo has overall survival benefit in this. And then this one, the abemaciclib, it deserves a mention because this is the only place where we can do single agent CDK4/6 inhibitor. Here, it was not combined with any endocrine therapy. And that's why you can say the PFS was also pretty small, only 6 months. But this was a very heavily pretreated hormone receptor positive breast cancer. Major differences in the various CDK4/6 inhibitors. Palbociclib and ribociclib are daily dosing. Abemaciclib is twice daily. Sometimes that can be nuisance for the patient, but then it compensates by having a continuous dose. So at least you can have, all those pills in a pill pack compared to these 3 weeks on, 1 week off, which sometimes can confuse certain patients. The overall response rate in monotherapy, abemaciclib is the clear winner here. And it also penetrates in the CNS, although we haven't studied it in brain metastasis yet. All of them cause cytopenias, all of them cause fatigue. Abemaciclib probably a little bit more nausea and diarrhea than the other thing, and than the other drugs, and ribociclib causes QT prolongation. They can all rarely be associated with pneumonitis. Now, another thing that's kind of changing now is, this was an old slide that says that once you progress on a CDK4/6 inhibitor, there is no point continuing one after that. However, this has recently changed. Now there's this recent presentation at ASCO this year, which shows that after you progress on palbociclib or abemaciclib, the switch of therapy to ribociclib has some benefit in PFS. But these are premature data right now, so clinical decisions should not be taken based on that. Now we're going to take a step back again and move back to the pre-CDK4/6 era. Fulvestrant is a drug that has a remarkable comeback story. When it initially came on, it was kind of rejected as an endocrine therapy because, first of all, if you have experience giving Faslodex injection, it's quite painful. You have to give two injections. Both of them are pretty big, and you have to really push hard to get them into the gluteal muscle. Plus, it's very expensive. Each injection costs more than $1,000. Plus, it didn't work as well like the other hormone therapies. But later, that's why this trial was very important, the confirmed trial, which showed that actually this is the proper dose, where you actually do kind of a loading dose, and instead of the 250 milligram, do the 500 milligrams. And then you do every 2 weeks for 3 times, and then you go on for every 4 weeks. And just by this increase in the dosage, there was a 4.1-month increase in overall survival. So that was fulvestrant compared to itself, just in a different dose. And then there were 2 other studies where fulvestrant in the high dose, in the 500 milligram dose, was compared to anastrozole and actually worked better. And then in the Falcon study, this was again compared with anastrozole. So this graph was for visceral disease, and this graph was for non-visceral disease. So it looks like if these are just to further decide which is the ideal patient in which you're going to start monotherapy with fulvestrant. And it's basically is somebody with non-visceral disease that is not a good candidate for CDK4/6 inhibitor because of some comorbidities. So fulvestrant is a very good option for such patients. Now, this trial, the SWOG S0226, it was comparing anastrozole to anastrozole plus fulvestrant, another option in the hormonal therapy setting, and that shows that anastrozole plus fulvestrant does increase the PFS and the OS, and whether you received and the benefit is more so if there is no previous hormone therapy. Now, this would probably be the last pathway that we talk about, the PI3K, AKT, mTOR pathway. This is a continuous pathway made by these three major proteins, but there are other proteins involved there as well. And in the end, they stimulate the RB gene in the DNA and cause cell division and growth factor signaling. So this pathway has been proven to be involved in the development of endocrine resistance. And these are these three trials that are very, very important. They all target this pathway. The first two, they target the mTOR pathway, and the last one, PI3K. So TAMRAD trial, it combined tamoxifen with everolimus versus tamoxifen alone. And these are, this is second line. So patients have already progressed on one treatment. So we divided them into primary resistance versus secondary resistance. Primary resistance meaning they progress within 6 months of the first line endocrine treatment. And looks like, that there was a clinical benefit rate of 61% versus 42%, so quite significant. And then the Bolero trial, it again tests the everolimus in the second line setting. And again, it improved the progression-free survival from 4.1 months to 10.6 months. And that established this regimen, the everolimus and the exemestane, the two E's, as one of the major hormonal regimens in the second and third line setting. And the SOLAR-1 is a very important trial that included patients with or without the PIK3 mutation and stratified according to that, and then gave a PIK3 inhibitor, alpelisib. And looks like in the patients who harbor this mutation, the PIK3 mutation, there is a significant improvement in progression-free survival. Patients without this mutation really don't benefit. So this mutation is predictive of response to CDK4/6 inhibitor. The PIK3 inhibitor. And luckily, this mutation is present in about 40% of HR-positive breast cancer. So the side effects: hyperglycemia, diarrhea, and rash. And just a quick overview of the approved options. We have many options for metastatic hormone receptor breast cancer now. So the outscape looks good, but really the issue is which patient is ideal for what treatment. And then chemotherapy is there, but we usually don't use it unless somebody completely runs out of hormonal treatment. Thank you very much.
Thanks a lot, Dr. Ahmed, for such a comprehensive talk. I would like to invite the next speaker, Dr. Haider Abbas, a consultant medical oncologist at Queen Elizabeth Hospital, Birmingham, UK.
Slides. This one. Okay, good afternoon, everyone. I thought I got away with this presentation, but somehow we managed to retrieve it. As Abdullah has been very kind in introducing me, and I'm really humbled. So as Abdullah said, I am a medical oncologist at Queen Elizabeth Hospital, Birmingham, and I treat lung and breast cancer. Now, these are my disclosures, and I want to add one more disclosure, and that is I'm proper jet lagged.
I've landed 8 in the morning and I'm not able to sleep. So if you see instances just because of jet lag, not that I don't know my stuff. So I've already covered myself for any problems that may occur in this presentation. So your job is to keep me awake. We all had food, so I think you're more likely to fall asleep than me. So it's just a tussle between you and me who goes to sleep first. But keep it short so that we are sort of involved in this. So what we'll go through is a bit of background to triple negative breast cancer. I'm really sorry if it's repetition. I know most of you would know this data, but for those junior doctors who are just starting oncology, I just thought just introducing a little bit more about triple negative, then histological subtypes, and then rationale of using immunotherapy in triple negative, and both in metastatic and in neoadjuvant setting. Now, first of all, how would you define a triple negative breast cancer? It's a very simplistic definition of triple negative, a subgroup which is negative for ER, PR, and HER2. Now, you would think that we have classified this and this group should behave in the same manner, but it's not as simple. All of us who treat breast cancer, we know that this doesn't happen. You'll have a group of patients who respond very nicely to chemotherapy, particularly in curative intent treatment. You see the tumor melt away and you have a durable response. But then there'll be patients whom you give treatment. The moment you finish your radical treatment, they would progress and it won't give you any opportunity. And if it's in metastatic setting, the patients keep on progressing one after another and after another. So even clinically, we know it's not homogeneous, it's extremely heterogeneous group of patients that we are treating. Now, if we want to look at a molecular subtype of breast cancer, it's the pivotal paper which was published in Nature by Peru et al. And what they did, they look at molecular subtype of breast cancer. And what they found was that the basal type that we already know, luminal type that we already know, the HER2 positive, and then there was another group, which they called basal-like group. And it was very much different in terms of gene expression as compared to other two groups. They had a basal markers, CK5, 6, 14, or 17. They were very aggressive. Most of these had P53 mutations, so extremely heterogeneous and aggressive group, which most of it is a triple negative cancer. Now, what are the challenges? Why is it so challenging to treat triple negative breast cancer? Because it's widely heterogeneous, as I said earlier. It is heterogeneous based on histology, although invasive ductal carcinoma remains the predominant type. It's heterogeneous based on biology. So if you look at DNA and RNA sequencing of these tumor subtypes, you see that there's not one, there are 4 or 5 different types of subgroups within the triple negative that we are treating. And more importantly, recently, that's microenvironment. If you look at the microenvironment, there's completely big range within triple negative breast cancer. And it all depends on infiltration of lymphocytes, how hot the tumor microenvironment is, and also about macrophages and all this that is in that. And it becomes very important in view of immunotherapy that we are going to offer to our patients. So these are some of the intrinsic subtypes of triple negative breast cancer. We pretty much agree that there are 4 main subtypes. 2 of them are basal-like immune suppressed and basal-like immune activated. Now, this one has got a really good prognosis. In these group of patients, there is already a talk about de-escalating your treatment. And basal-like immune suppressed has got worse prognosis. That this is the group of patients whom you give chemotherapy, they don't respond. They keep on progressing one after another line of treatment. So you can't treat all of them exactly the same manner. And luminal AR, they just sort of respond to androgens. It's quite heterogeneous, as I've explained earlier. Now, first of all, let's have a look at immunotherapy in metastatic triple negative breast cancer. And like any other tumor site, you normally start with a metastatic setting. You have your drugs and then you move them to neoadjuvant or curative intent treatment. Now, what you're looking at is a distribution of tumor mutation burden across various tumor types. And we know that tumor mutation burden is a very important predictor of response to immunotherapy, although not the only, but one of the very important ones. And then from Charles Swanton's work, we know that it's also about the quality of tumor mutation. So if you look on the right, you have melanoma and non-small cell lung cancers. Their mutation burden is somewhere in the range of about 10 to 15 mutations per megabase. So they are very likely to respond to immunotherapy. And we do see quite durable and good responses here. And here you have less than one mutation per megabase, and these don't respond. If you look at breast, it's just sitting right in the middle. So not ideal type of tumor that you would want to give immunotherapy, but still there might be some opportunities here. Now, if you look at within breast cancer, you'll find that all those indicators which are required to respond to immunotherapy, like tumor infiltrating lymphocytes, PD-L1 expression, and non-cinemus mutations, you see that the basal-like or the triple negative have got highest chances of highest chances of response, because if you look at basal-like, they've got maximum non-cinemus mutations among breast cancer. Similarly, PD-L1 expression. So it's all about among all different types of breast cancer, triple negative should be the one which should respond to immunotherapy. Now, the data that we have in metastatic setting comes from two important immunotherapy drugs, atezolizumab and pembrolizumab. And these are early phase data. And what really we have learned from this is you would only see a response in first line setting. So if you have atezolizumab or pembro in first line, single agent, you'll see a response of 26 or 23%. As soon as you go to second line and beyond, your response rates drop. And the same is the thing with progression-free survival, duration of response. It's usually the first line that you get you get the response. As soon as you move beyond, there is nothing at all. Now, why do we have to combine immunotherapy along with chemotherapy? We know that chemotherapy just changes the microenvironment. It makes it more inflamed. It produces a lot of new antigens, and it just sort of clicks the immune system, makes it more feasible for immunotherapy to work. So that was the rationale of combining immunotherapy along with chemotherapy. And we have seen the results, particularly in non-small cell lung cancer with chemo-IO combination. You see really good results as compared to immunotherapy on own, particularly in PD-L1 negative tumors. Is PD-L1 a biomarker? I think it's very important to understand how do we test for PD-L1 expression for different drugs. So if you look for pembrolizumab, it is tested by DECO22C3. It tests for PD-L1 expression in lymphocytes, macrophages, and the tumor cells. And then you divide it by total number of tumor cells times 100. And this gives you a score called CPS, or combined positive score. In contrast, for atezolizumab, you have to use a different assay, Ventan SP142, and it only looks for immune cells. So the bottom line is you have to use the right assay for the right drug, because you would not get the right results. Now, if we look at the reason why you have to use the proper test for each is if you have the same sample and tested by 3 different approved assays, you'll see a difference. By SP142, you'll see 46% of patients being positive for PD-L1. 22C3 will show 81%, and SP263, 75%. So you have to use the right assay for the right drug. So in metastatic setting, this is the trial which completely changed the way we are treating triple negative breast cancer. Because it has always been very grim. You had chemotherapy after chemotherapy and after chemotherapy. And this trial essentially changed the whole story about it, improving overall survival and progression-free survival. This work was done by Peter Schmidt and was published in Lancet in 2018. So essentially, patients with relapsed metastatic triple negative breast cancer or de novo presentation, well, majority of them, about 60 to 70%, were relapsed. They were randomized to atezolizumab versus placebo, along with nab-paclitaxel. Now, the reason why nab-paclitaxel was selected, because as you know that nab-paclitaxel doesn't cause allergic reactions, and you don't need to give steroids along with it. And we want to avoid steroids in immunotherapy because you don't want to counteract, you don't want to dampen your immune system. So that's why nab-paclitaxel was selected. And the primary endpoint, the co-primary endpoints were progression-free survival and OS, an intention to treat population, and PD-L1 positive subgroup. So if you look at intention to treat population in PD-L1, progression-free survival was improved from 5.5 to 7.2 months. Although it's numerically improved, but your hazard ratio doesn't cross statistical significance, its hazard ratio is 0.8, and it wasn't sort of approved for intention to treat. However, in PDL1, if you look at it, your PFS is improved from 5 to 7.5 with hazard ratio of 0.62. And that was a game changer in triple negative. And this was the first drug to be approved as an immunotherapy for triple negative breast. Now, if you look at overall survival, once again, you can see that patients in intention to treat, you don't see any difference. However, it's a marked improvement of 25 months of overall survival from 18. So OS of 18 months without immunotherapy, moving up to 25 months is for the first time ever we saw a 20-month, crossing the 20-month mark in a triple negative breast cancer. So clearly, not only progression-free survival, but also your overall survival is improved, and with a remarkable hazard ratio of somewhere around 0.6. Overall survival, so this was another subgroup analysis looking at PDL1 negative and PDL1 positive. Now, if you're PDL1 negative, it essentially doesn't do anything. You have to be a PDL1 positive for OS benefit, which is from 18 to 25. So very clear signal. Tumor has to be PDL1 positive for atezolizumab. Now, the next trial, Keynote 355, it was a pembrolizumab, pretty much similar setting, but this was published 2 years late. This trial started later. The core primary endpoint when the trial was initially designed was both to look for OS and progression-free survival, both in intention to treat population and PDL1 positive. However, after the atezo data was published, they made an amendment, and it just came to only review OS benefit and PFS in CPS greater than 10. So PFS in intention to treat population, you can see it has improved from 5.6 to 7.5 months, essentially a couple of months of benefit with pembrolizumab, but that's for all comers. Again, it is not statistically significant. You can see some numerical benefit here. Now, CPS greater than 1, which you would call PDL1 positive, but it's not as strict as PDL greater than CPS score greater than 10. You still see some signal here. It has improved from 5.6 to 7.6 with hazard ratio of 0.7, still not crossing statistical significance, but that's where the main benefit is. It is positive in CPS greater than 10. OS is improved, PFS is improved from 5.6 to 9.7 months with a hazard ratio of 0.65. And once again, it confirms exactly what we knew from the previous study, atezo study, that immunotherapy works in combination with chemotherapy, and it has to be PDL1 positive. Now, if you look at subgroup analysis, I think we have to be careful when we look at subgroup analysis because these numbers are not powered enough to tell you exactly the benefit, but there's a signal that if you use taxanes, you are slightly better off as compared to gem carbo, but again, one has to be very careful. All the chemotherapies worked, and essentially no benefit in CPS greater than 1. The only benefit you see is CPS greater than 10, pembro adding with any of the chemotherapy regimens, nab-paclitaxel, paclitaxel, or gem carbo. Yeah, that's pretty much a summary of the important trials. We have essentially talked about it. Now, what have we, if to summarize immunotherapy in metastatic triple negative, benefit is limited to PDL1 positive patients. It has to be given in first line, but in combination with chemotherapy. Long-term benefits are less durable than expected. Now, what happens with immunotherapy, we know with melanoma and lung, you'd see about 20% of patients doing a long-term survival as compared to any other systemic treatment, but that's lacking in triple negative. You're not seeing that long-term survival with this, and we can come to it later on if we have time. And autoimmune toxicity is a serious concern. Having said that, I think grade 3 toxicity, all grade toxicities were greater than in about 26%, but grade 3 and above was only in 5%, which is very much manageable now. So in neoadjuvant setting, again, two important drugs, pembrolizumab. Now, in this phase 3 randomized controlled trial, patients were randomized to pembrolizumab versus placebo, along with carboplatin paclitaxel, along with either docetaxel cyclophosphamide or epirubicin cyclophosphamide. So there were 8 cycles of treatment. Patients have surgery, and then they have another 9 cycles of pembrolizumab or placebo. So essentially, the core primary endpoints were event-free survival and pathological complete response. And as expected, you can see it met its primary endpoint. You can see it improved in intention to treat population. The PathCR was improved from 51 to 64, which is about 13.6% improvement, which is a very, very big thing. It's really game changer. By PD-L1 status, not a much difference, although it was not powered enough. The numbers are small, so I won't worry too much about it. You would say, well, PD-L1 negative got a bit more benefit as compared to PD-L1 positive, but the numbers are not that enough to just tell you whether it is significant or not. But there's a clear signal, PD-L1 positive, immunotherapy in neoadjuvant settings improved PathCR irrespective of PD-L1 expression. So this is event-free survival. It's early data. We have to wait for data to mature to see what happens in the long term. Now, atezolizumab data pretty much similar to pembrolizumab. Patients were randomized, but hey, the chemotherapy backbone is different. They have used nab-paclitaxel for 12 treatments, 12 weekly treatments along with atezo, followed by dose-dense doxorubicin and cyclophosphamide, 8 weeks or 4 cycles of treatment. And then pretty much similar, they have surgery and then they move on to have 11 doses of atezolizumab. And here the primary endpoint was pretty much similar. You're looking at PathCR event-free survival. And once again, as expected, it is improved PathCR from 41 to 57.6%, which is pretty much similar to what we saw with pembrolizumab, about 13 to 15% improvement in pathological complete response. By PD-L1 status here, I think we are a bit more confident because PD-L1 positive get a bit more benefit as compared to PD-L1 negative. But again, the numbers are small. I think it's a clear message that if you are PD-L1, if you have to give immunotherapy, works in neoadjuvant setting irrespective of PD-L1 expression. And now just to compare these two main trials, I think we've talked about it. PathCR improves. We are lacking long-term data to see what happens, and that's really important. One thing which I want to touch upon is how good is a PathCR as an intermediate biomarker, just to tell you whether a drug is good enough or not. And that's pre-immunotherapy era. Kotza et al. Published it in Lancet 2014. It's not an excellent biomarker, but you see if patients achieve pathological complete response, 15 to 20% of them would relapse or die, which means about 80% of them are fine. They're essentially cured. And then if patients don't even get PathCR, 50% of them would neither die nor relapse. So it is an important endpoint, but not a perfect endpoint. And with immunotherapy coming in, I think it becomes important to see what the long-term survival is of these patients. Now, if I have to summarize, I would say that in neoadjuvant setting, immunotherapy works irrespective of PD-L1 expression. The survival data needs to mature to confirm long-term benefits, and autoimmune toxicity was pretty much similar to a metastatic setting and is very much manageable in view of how much immunotherapy we use now. Thank you.
Thanks a lot, Dr. Abbas. Now it's the last talk of the session from Dr. Dave Tripathi, a very good friend of mine. He's a consultant clinical oncologist at New Cross Hospital, Wolverhampton, United Kingdom. He specializes in breast cancer and head and neck cancers, and is the lead of stereotactic radiotherapy and the lead of breast cancer at his institute. It's going to be a virtual talk.
Hello, everyone, and thank you for inviting me to give this talk. My name is Dr. Devashish Tripathi. Hello, everyone, and thank you for inviting me to give this talk. My name is Dr. Devashish Tripathi, and I'm a consultant clinical oncologist at the Royal Wolverhampton NHS Trust, UK. My sites include head and neck cancers, breast cancers, and stereotactic radiotherapy. And I'm going to talk to you today about the role of stereotactic ablative body radiation, or SABR, in the treatment of oligometastatic breast cancer. So we will begin with a bit of background on radiotherapy, on SABR basics. SABR is a form of high precision image guided radiotherapy, which is used to deliver a high dose of radiation to the tumor in a limited number of fractions. Typically, this is between 3 to 5 fractions, but sometimes more number of fractions might also be used. Stereotactic radiosurgery refers to a single fraction treatment given to intracranial and spinal targets, whereas stereotactic body radiation therapy, which is called SBRT or SABR, depending on where one lives, refers to multifractional treatment given to intracranial, spinal, or extracranial sites like the lung, head and neck, liver, pancreas, and prostate. The main advantage of SABR over conventional radiotherapy is that it gives a steep dose gradient, allowing delivery of very high biologically effective doses to the cancer, while minimizing the radiation exposure to the neighboring normal tissues, thereby limiting toxicities. How does SABR work? The radiobiological rationale for hypofractionation is the delivery of a few large fractions over a short overall treatment time that will achieve a greater therapeutic ratio, which is the relationship between the probability of tumor control and the likelihood of toxicity, than the delivery of standard treatment, which might be 20 or more fractions. The clinical efficiency of SABR, however, is greater than what we would expect by conventional radiobiological principles. The reason for that is that SABR not only ablates tumor cells directly, but also induces indirect effects like vascular endothelial injury and immune activation, which is also called the abscopal effect. This indirect tumor cell death by SABR may play a crucial role in cell killing and gives it that extra punch. How is SABR delivered? The delivery of SABR can be through a variety of devices. In this slide, in the center, you can see a conventional linear accelerator, which is what most departments use. The LINAC can have a cone beam CT for IGRT treatment. The couch can also have 6 degrees of freedom, which helps in more precise localization and by reducing the errors in positioning the patient. On the left-hand side, you've got a tomotherapy machine, which can again be used for delivery of SBRT treatment. And on the right, you can see a CyberKnife machine, which has a mobile linear accelerator mounted on a robotic arm. It tracks the tumor and delivers very precise radiation beams. Next, we come to the concept of oligometastatic disease. Historically, the treatment of patients with metastatic solid tumors has been based on systemic therapies that aim to delay tumor progression and extend the patient's life, but in principle cannot eradicate the disease completely. Numerous single-arm studies over the years have suggested that long-term survival is improved after these ablative treatments. However, the few of these studies which had adequate controls raised the possibility that this long-term survival may not have been because of the treatment itself, but because of the careful selection of patients based on favorable inclusion criteria. So there is something called the oligometastatic paradigm. This paradigm emerged from a realization that traditionally accepted contiguous and systemic theory of cancer pathogenesis may not be adequate to explain and manage metastatic cancer and may be actually too restricting. The contiguous theory considered cancer spread to be in a very stepwise and orderly fashion, extending from the primary site to the local regional lymph nodes and then to distant sites. Whereas the systemic hypothesis was just the opposite. It said that systemic metastases are a part of a widespread disease with subclinical micrometastases. So as per this theory, the treatment of local metastasis should not affect the patient's survival. But the oligometastatic theory proposes the existence of a state, which is called the oligometastatic state, where the metastasizing cells may seed certain sites and organs, and aggressive
local treatment of these sites may eradicate metastases entirely and thereby could be potentially curative or extend the patient's life. So the latest EORTC and ASTRO recommendations agree with the widely held consensus that patients suitable for oligometastatic treatments should have between 1 and 5 detectable metastases. But ultimately, a combination of factors define the oligometastatic state, including patient factors like age and performance status, tumor factors like the histology or a controlled primary tumor, and disease burden, that is the volume of detectable metastatic disease. Now, in this slide, I have included a few randomized controlled trials which have looked at metastasis-directed therapy for oligometastatic disease. I've taken this table from the journal Clinical Oncology published by the Royal College of Radiologists. And you can see that there have been several RCTs which have reported now, which looked at local treatment like SABR, metastatectomy, or radiofrequency ablation. And in particular, there was the SABR COMET trial in which various histologies were included, and it did show progression-free and overall survival benefit for SABR over the treatment of investigator's choice. So we are going to focus on this trial in the next few slides. But first, there was also this meta-analysis which looked at 21 single-arm prospective trials. And the most common tumor types in these trials were prostate, colorectal, breast, and lung. What this meta-analysis found was that the one-year local control was about 94.7%. The one-year overall survival was 85.4%, and the PFS was 51.4%. And the rate of grade 3 to 5 acute toxicities was quite low, between 1.2 and 1.7% for early and late toxicities, respectively. So coming to the SABR COMET trial, about which I spoke earlier, this was a randomized phase 2 open label trial in which patients with controlled primary tumor and between 1 to 5 metastatic lesions with reasonably good performance status and a good life expectancy of at least 6 months were enrolled. On the left-hand side, you can look at the site of the original primary tumor, and in the control and SABR group, 15 and 20% patients respectively were from the breast cancer cohort. What this trial found was the median overall survival was 41 months for the SABR group versus 28 months for the control arm. However, it found that the rate of adverse events was significantly higher in the SABR group. And worryingly, there were 3 deaths in the SABR arm compared to none in the control group. Looking at this slide, you can see on the left the Kaplan-Meier curves for both overall and progression-free survival, and there's a wide divergence showing benefit for the SABR arm over the control arm. And on the right-hand side, you can see the toxicity data. And as you can see, the adverse event, the proportion of patients having more than grade 2 toxicities was 61% in the SABR arm versus 46% in the control group. And most of these toxicities were fatigue, shortness of breath, and local pain in the chest wall or in the muscles. So the trial data is there for us to see, but what is also important is real world data. And for this, NHS England funded, this is in 2015, NHS England funded a prospective single-arm observational evaluation study of patients with solid cancers and extracranial oligomets, which were treated with SABR. The study was done at 17 NHS radiotherapy centers in England, And patients were eligible if they had solid malignancy with 1 or 3 extracranial metastases, disease-free interval from the primary tumor to development of mets of more than 6 months, a WHO performance status of 2 or lower, and life expectancy of at least 6 months. And the primary outcome in this trial was overall survival at 1 and 2 years from the start of treatment. So these are the curves on the right-hand side for local control and overall survival. And this trial showed that the overall survival was 92.3% at 1 year and 79.2% at 2 years post-treatment. And the proportion of patients experiencing grade 3 to 5 toxicity was less than 2%. And there were no deaths in this real-world study. And in this slide, I have included the breast cancer specific outcomes from this study. As you can see, about 78 patients in this study were breast cancer patients. And in terms of overall survival, the breast cancer patients did approximately the same as the overall group, with 93% survival at 1 year and about 83.2% patients surviving to 2 years. So these are the indications for treating oligometastatic disease with SABR in the NHS. This has been taken from the National SABR document. And as you can see, the patients must meet all of the following criteria to be eligible for SABR treatment, including confirmed histological diagnosis of a metastatic primary cancer, a disease-free interval between the primary treatment and manifestation of metastases to be at least 6 months, 1 to 3 extracranial sites confined to 1 or 2 organs. In addition, a life expectancy of 6 months and a reasonably good performance status of less than equal to 2. But there are certain peculiarities in breast cancer which can also affect the outcomes and can be prognostic factors. We know from studies that the 5 and 10-year overall survival after SABR for patients with bone-only metastasis compared to patients with metastatic lesions at other site was 83 and 75% respectively at 5 years and 31 and 17% at 10 years. So patients who have only bone metastases tend to do better than patients with visceral metastases. We also know that the prognosis on survival endpoint declines with an increasing number of METs. Synchronous metastases have a better overall survival than metachronous ones, but oligoprogressive cancers tend to do much worse. And tumor biology suggests that triple negative breast cancers treated with SABR have a much poorer prognosis. So it would be very helpful to have RCT data which is specific to oligometastatic breast cancer, because as you've noticed so far, most of the data is either from other tumor sites or from a mixed group with a relatively limited number of breast cancer patients. So this slide shows you different ongoing RCTs which are including breast cancer patients. They are testing different modalities, including SABR, metastatectomies, and radiofrequency ablation. And in most of these trials, the number of metastatic lesions have been limited to 5 or lower. So in conclusion, SABR is a promising treatment option for patients with oligometastatic breast cancer and offers a high rate of local control with limited and manageable toxicities. Prospective cohort studies have shown favorable results in selected patients, and there is also randomized trial data which has included patients with breast cancer. But further randomized control trials are needed to conclusively demonstrate an additional benefit of SABR in the setting of optimal systemic therapy. Thank you very much for listening patiently. Have a good day.
Thank you so much, Dave. Now I would like to invite Dr. Fahad and Dr. Haider to join the discussion panel, please. And we've got around 15 minutes for any questions.
Okay, hi, I'm Romina from Molecular Diagnostics from Shaukat Khanum Hospital. I was just wondering, Dr. Heather, I think, gave a talk on PD-L1. Okay, so I was just wondering if you have looked into high mutation burden or MSI as well, together with PD-L1?
We don't actually look for it. But I think the important thing is, as I mentioned earlier, it's not just one tumor mutation burden or PD-L1 expression. There's so many different things that would determine whether a patient responds to immunotherapy or not, like MHC loss, quality of mutations. If they are clonal mutations, they tend to respond. Subclonal mutations, no matter how big the tumor mutation burden is, it would not work at all. So there's so many different things, and we're just trying to pick up. So we would not, are you talking just about breast cancer patients?
Yes.
Not really. I think in UK, it's all government-funded healthcare system. So we would only do what is required to sort of treat a patient. So at the moment, PD-L1 testing is for triple negative, and that would determine what treatment we offer, and that's what we do.
Okay, thank you. But whatever I have read in the literature and other breast cancer cases, I have seen and observed that if you have T1 mutation burden, high T1 mutation burden, because these are two variables for immunotherapy together with PD-L1 and also PD-L1 percentage, if that is higher and also T1 mutation burden is higher, then the immunotherapy response is really good. So I was just wondering if you have looked into that. Okay, thank you.
That's true, because if you look at, you need to look at what is the actual cause of cancer. In lung cancer, you see tobacco, and that's going to cause a lot of mutations. In skin, melanoma is ultraviolet light, you're going to get a lot of mutations. In breast, you're not going to get a lot of mutations. They're quite homogeneous, plain tumors, not a lot of mutations anyways. So you're not going to get a lot. Whatever you get within triple negative, you highest chances of getting any response to immunotherapy.
And I would echo the same. We are using the PD-L1 status as our major criteria. It makes sense that TMB is high, the PD-L1 would be high because the mutational burden, but the studies that have been done, we don't have that data to support that TMB status can be used in place of PD-L1 status. So.
All right, so I'm a resident of radiation oncology. My question is specifically for the last speaker. I don't know if he's available or not, but the question is that how do you see the role of SABR in polymetastatic setting? Someone who responded to chemo, but now they are either in oligo refractory or resistant. So how do you see the role of SABR in this scenario?
I'm not a clinolog, sorry, but
yes, that's why I cleared that I'm a resident of radiation oncology.
Well, I'm sorry, Dave is not with us, but we've got another clinical oncologist, Dr. Habib Khan, so he would help us with the answer.
It's a very good question. So you've seen the data of the SABR comet, which had proven that you can control the disease. So you have to look at it, and triple negative breast cancer did not well, because they are more aggressive tumors. So it's quite makes sense if your tumor load or primary tumor or the metastatic disease very well controlled, and you've got oligometastatic disease, 1 to 5 number. And if you want to treat them with a SABR or conventional radiotherapy, it's quite reasonable. And you can get a local control. It won't provide you the systemic control, but if you have a good systemic control, it's quite reasonable to consider SABR or any other focused treatment that you can use. Thank you.
So in early, I'm Dr. Musaddiq, so I want to ask a question. In early breast cancer, do you check PD-L1 status for immunotherapy? And is there any role of PD-L1 relationship of PD-L1 status with the response to neoadjuvant immunotherapy?
Sorry, I didn't get your question. So you want us to, do we check PD-L1 in breast cancer? You mean?
Early breast cancer for neoadjuvant chemotherapy or chemoimmunotherapy, do you want to check the PD-L1 status? So, and is there any relationship of the response to neoadjuvant therapy?
Right. So in a neoadjuvant setting, we don't, because you don't need it. It is irrespective of PD-L1 expression, patients would still respond. There was a bit of a hint in Atezo data that if patients with PD-L1 expression high, they tend to do slightly better. But as a whole, it's not statistically significant. Anyone, irrespective of PD-L1 expression, would respond. In metastatic setting, yes, we will do, and depends on which drug you want to give. Now, that's another discussion, whether you want to give pembro or atezo, depending on the previous history. Younger patients where you think there's a bit of BRCA there, I would normally go with pembro. But pembro gives you a bit of flexibility of which chemotherapy arm you want to use, or not, backbone you want to use along with it. So yes, in metastatic setting, yes, we would. In neoadjuvant curative intent, no, we don't need to.
So another question in continuity. So like, why, what could be the reason behind it? We don't need PD-L1 status in early breast cancer in metastatic setting. We need it. Logically, I think metastatic setting should have higher number of antigens and higher response to immunotherapy.
Yes, you're right. But I think with immunotherapy, we are learning as we're moving on now. Just like I said, in the atezo data, if you look at it, in metastatic and impassion 131 was negative. That was atezolizumab with paclitaxel. But here, if you look with pembrolizumab, it works with nab-paclitaxel, and carbogem. So there are certain things which we are not clear, and had a lot of discussions even with big guys who are involved in the research. There are things which were not clear, and one of the reasons is that it's not only one determinant why a patient should respond. As I said, PD-L1 is one of those things. You also need to know the quality of mutations. You also want to know whether MHC1 is lost or not. Loss of heterozygosity of MHC1. So there's so many things. PD-L1, we don't just call it the only way by which you can determine. It's not the only biomarker to tell you whether the patient is responding or not. Yes, I take your point, but it might be that early breast cancer behaves differently as compared to metastatic. They might have developed some more mutations. I think that's probably the reason. And I think with time we'll probably know, but at the moment, I don't think so. We know the answer for this.
And that's exactly why the clinical trials are important, to know the answer to these questions.
Has anyone else got a question? Yes, Dr. Abdul Manan.
So my question is that how practical is it to how practical is it to repeat the immunohistochemistry in the triple negative breast cancer after giving neoadjuvant chemotherapy and after the surgery if you get the residual disease? How practical is it to do the immunohistochemistry on that residual disease?
I think that's one of the histopathology colleague here who can probably tell you that. Probably because she was here, she asked a question, she might have left by now. I don't think so. That's challenging. I see it's pretty straightforward.
I want to know about the practicality of that. I mean, if it was a triple negative disease and on the residual disease, you repeat the immunohistochemistry and it comes back hormone positive then. So would you start the patient on the endocrine therapy or would you give the capecitabine as per the Creatix trial? So
I think you, right. So is your question that after PAT-CR, would you continue with capecitabine or is that your question?
No, if there's no PAT-CR, so would you repeat an immunohistochemistry again on the surgical specimen or would you treat it with the capecitabine?
You don't need to repeat it. Even in the clinical trials, what actually happened was initial biopsy, you just get on with your treatment and then you have surgery and then you finally if PAT-CR or no PAT-CR, you give the adjuvant part of pembrolizumab and then you sort of carry on. The question can be like, if you don't have PAT-CR, what do you do? Do you give capecitabine or continue with immunotherapy? Now, that's a difficult one to answer, and that's evidence-free zone, which means you can do whatever you want within reasonable reasons. So when this trial was done, Keynote 522, Creatix data wasn't presented, so they did not include any capecitabine. Now, my question there is, if a patient has not responded to 8 cycles of neoadjuvant chemotherapy, along with immunotherapy, what actually you're trying to achieve by giving some capecitabine, right? This is that group of triple negative, which is not going to respond no matter what you do. So this is that Bliss subgroup, which is immune suppressed. No matter what you do, they're going to progress. So you can and you can't. I think if you're purist, you shouldn't do it. If you want to just have a reasonable discussion with a young girl who's got lots of nodes involved, and probably you can have a chat, but I don't think so that's going to make a huge difference.
Okay, and one more question if I can. So sometimes what happens is that you get a low.
Sorry, can you come close to the microphone here?
So sometimes what you get the patients who are low ER positive, like 1 to 10%. So you treat them with the neoadjuvant chemotherapy and you do the surgery, and if you get the residual disease, in that scenario, would the adjuvant endocrine therapy would be more beneficial, or would you treat it with the capecitabine?
So you're talking about ER.
Yes, ER positive, 1 to 10, HER2 negative.
So there is no data such that you have to base your treatment based on Ki-67 score. There's good enough evidence there that if your Ki-67 score drops with endocrine treatment, these patients tend to do much better, but there is no evidence as such that you have to determine your treatment. You always determine your neoadjuvant treatment. I think there is one thing I would always do is, if you cannot avoid adjuvant chemotherapy, give them neoadjuvant. Reason being, you have a good feel of biology of the tumor. You would know whether you have, and the other thing is you can turn these patients into path CR, which tends to be a better outcome. And if your patient has no response whatsoever, you know that you're dealing with a horrible tumor. And when the patient comes back with relapse, you would know that this was expected because you did not respond at all. So my rule of thumb is, if you cannot avoid adjuvant treatment, go for neoadjuvant, but you have to be mindful of oncotype DX. If someone is N1 positive, postmenopausal, I would not. I would let them have treatment, then oncotype DX, and then probably try to avoid chemotherapy. So these are things that you have to look for.
No, but my question was that if it's a low ER positive, 1 to 10%, and the patient comes for the neoadjuvant chemotherapy, and we have started neoadjuvant chemotherapy. After the neoadjuvant chemotherapy ends, she goes for a surgery, and she has some residual disease. But so in that scenario, would it be treated as a triple negative breast cancer getting the capecitabine, or would it be the endocrine therapy?
Ki-67 doesn't affect your treatment choices. You should be treating patients irrespective of Ki-67.
Let me clarify. So what Dr. Abdul Manan is asking is, like, patients who are weakly ER/PR positive, whether we should be treating them as ER positive or whether we should be treating them as triple negative.
Yeah, so that's an interesting one, because what you do when you have an ER4 positive patient, right? We have sent a number of oncotype DXs on these patients, and it always comes back greater than 70. Now, these group of patients, ER4, 5, they are sort of abandoned group. They're not included in triple negative. They're not in ER positive trials, but I tend to treat them more like triple negative rather than ER positive. They are going to behave like triple negative. You're going to have a good response. And again, ER positive is a spectrum. It's not like plus or negative, plus or minus, as you'd get with HER2. So I would treat them on the spectrum more like triple negative rather than ER positive.
Yes, Dr. Fad, would you like to add anything?
No, I think that's very reasonable. So if it's a weekly ER/PR positive, I would treat it as a triple negative, because I don't expect a good response with my hormonal therapy at that point. So.
Yes, please.
Do we have time? Okay, I'm Saira Salim, and my research is centered around cancer proteomics. And we all know that cancer is a pathway-driven disease. And we just say that the tumor is in breast, or tumor is in colon, or tumor is in lung. So we associate this HER2 expression with breast cancer most of the times. Do you think that we could use this HER2 expression and add more patients, like colon cancer patients, tongue cancer patients, to these clinical trials, and see whether these combination therapies that you are giving to the breast cancer patient, in order to see whether the HER2 expression is useful in deciding their treatment, would that be beneficial for the colon cancer patients, or lung cancer patients, other cancer patients as well?
So to answer your question, these are already included in the trials. We have got data in the gastric cancer space. We are using HER2 positive disease in the metastatic setting. Yeah. In the colon cancer, we don't have good data that's supporting HER2 right now, but it was worked on. In all these trastuzumab deruxtecan, these are like multi-tumor cancer specific. So we are using this in multiple settings to see if there's a benefit. In the lung cancer space, I can tell you HER2 mutant disease, not the expression, is being targeted right now. We have got target agents. So it's already ongoing. It's already in the studies. We are working on that. It's just the data, whatever comes out is being put forwards.
Right. So these clinical trials are
they are all
including
cancer
all
types
other
initially,
conditions.
and that's how we started as,
Right.
and then we see which one is benefiting more. But for the breast, it was a big deal when we came out with this Cleopatra and everything.
Sure.
So yeah, this is already, and I think we'll be more excited with the trastuzumab deruxtecan, the HER2 low, because that's a HER2 receptor. You are putting a chemotherapy payload on top of it, like the TDM1. So I think that will be a game changer than the trastuzumab and the other things that we already had in place. So look forward to it. I think there's great data coming out.
Okay, thank you. Thank you very much.
I would just add one thing. We have TDX2 data in lung, and we're using that. So it's pretty much, but lung is very different to breast. You know, it's a minefield of mutations. You try to fix one thing, something else goes off. You fix that and something else goes off. Whereas breast is very homogeneous. Right? If you have one problem, it tends to be the issue. It's not like mutations all over. So yeah, we have some improved. I think PF response rates about 40 to 50% with PFS improvement of about 4 or 5 months with TDX2 in lung, HER2 mutated.
Any more questions?
This is, so I'm audible. This is Dr. Azhar from Shifa International, Islamabad. My question is, as we mentioned in SOLAR trial, they had excluded patients who were exposed to fulvestrant previously. It's fulvestrant plus alpelisib or fulvestrant alone. So we get lots of patients who have previously been on AIs, couple of years, CD4 inhibitors, and fulvestrant. So my query is down the line, what to combine it with, tamoxifen or everolimus, or is there any evolving data on that? Thank you.
Right, so that's an interesting one because there's certain drugs when the trial comes in, you know, that's it. I want this drug like TDX2, but you don't even need to. It just hazard ratios are 0.22, which is never heard of. Now the problem with alpelisib is, which I use in clinical because it is there and patients would be asking for you, do I really believe in this drug? Actually, no. And why is that? Because all the data that you have from that trial is pre-CDK4/6 era. Right? No patients had CDK4/6 inhibitors in that trial where alpelisib showed some PFS improvement. And then real life data was done to see if it can make any difference in patients following CDK4/6 inhibitors, single arm phase 2 study. And even that showed progression-free survival improvement of 2 to 3 months along with fulvestrant, no OS benefit. So you have to be very careful. These are really expensive drugs. Using alpelisib in ER positive following CDK4/6 is a very difficult one to justify. You can't justify this really. Yes, it is when you have unlimited amount of money and your patient wants to delay their chemotherapy by 2 to 3 months, fair enough. Otherwise, anyone in the audience feel free to just justify why would you want to use alpelisib. It looks nice. See, you have it was expected to be a very positive clinical trial, but unfortunately came back as negative. But you can't justify it, to be honest. We can't. I just give it because it's NHS providing it and it improves PFS by 2 to 3 months, but no OS benefit as such. And you have to combine with fulvestrant. If patients have fulvestrant, you can't. You can only combine with fulvestrant.
So I use this as an AI CDK4/6 inhibitor in my first line, biopsy it again. If I find a PIK3CA, so I've got a couple of patients who I did put on alpelisib and fulvestrant in my second line. It just gives me room, another option, I guess. But you're right, like it doesn't give a major overall survival benefit, but it does give me some progression-free survival. And then I wait for the progression again, because it's a long game, it's a marathon. With a hormone-positive metastatic breast cancer, it's not like 6 months, it's like a marathon. So you have to put all these things into play, I guess, and use your best options.
Well, I would like to thank all our speakers and audience for all the brilliant talks. Thank you very much.